Hello, my name is Professor Pasi Jänne, and I'm a thoracic medical oncologist and the Senior Vice President for Translational Medicine at the Dana-Farber Cancer Institute in Boston, USA. Welcome back to this modular educational activity entitled Overcoming EGFR-TKI Resistance, Emerging Therapies, and Biomarker Strategies in Non-Small Cell Lung Cancer. In our first module, we covered the mechanisms of EGFR-TKI resistance and the latest advances in treating biomarker-selected patients with actionable resistance mechanisms. In the second module, titled Beyond Actionable Targets in EGFR-TKI Resistance, we will discuss beyond actionable targets, latest advances post-EGFR-TKIs, and optimizing treatment strategy. So first, it's important to note that several acquired resistance mechanisms to first-line, third-generation EGFR-TKIs have been identified. As we discussed in Module 1, some of the current known mechanisms include EGFR C797S, MET or HER2 amplification, and histologic transformation. However, in a significant proportion of patients, around 40 to 50%, so a significant subset, the mechanism of resistance to osimertinib has not been identified or fully characterized. To put this into perspective, only about 10% of resistance to first or second generation EGFR-TKIs remain unidentified. So what accounts for the high proportion of unexplained resistance? Some of this could be due to technical limitations of current assays or sample quality, which may prevent detection of resistance mechanisms. There could be non-gene level changes, such as epigenetic alterations, protein overexpression, which may be responsible for resistance, but which we're not addressing purely through genomic sequencing-based mechanisms. Finally, there's tumor heterogeneity and spatial diversity, which means a single tissue biopsy may not reveal all resistance mechanisms present in the patient's cancers. And this is a challenge when we think about the therapeutic approaches. Even in a clinical trial setting, sample quality and availability or assay limitations often prevent resistance mechanism testing. In the FLORA study, for example, only 39% of patients from the osimertinib arm were included in the resistance subset analysis. So the guideline recommended options in the first-line setting for patients with EGFR-mutant disease, NCCN guidelines currently recommend osimertinib monotherapy as the preferred regimen in the first-line setting. However, this is a rapidly evolving area with data that has emerged on using amivantamab and lazertinib in this setting in the Mariposa trial, as well as using osimertinib and chemotherapy with pemetrexed and platinum in the FLORA-2 regimen. And it is likely that the NCCN guidelines are soon to be updated, and all three of these regimens will be potential first-line options. Current NCCN guidelines, at the time of asymptomatic progression, the local therapy should be considered. This can be either local radiation therapy or surgery, and in some instances, surgery is warranted, for example, in symptomatic brain disease. If there's limited systemic progression, local therapy can also be considered if feasible. But when there is multiple areas of systemic progression, then other systemic therapies are needed. In the case of patients who started with osimertinib alone, the preferred regimen here is based on the Mariposa 2 trial of chemotherapy with carboplatin and pemetrexed and amivantamab, or other systemic treatment approaches. Although there have been recent advances, platinum-based chemotherapy has been the standard of care for patients with undefined EGFR-TKI resistance mechanisms, despite it having limited activity. In the absence of a specific resistance mechanism, biomarker-driven approaches are not feasible, and clinicians have limited information to help determine the choice of second-line therapy. Compounding this challenge, CNS disease is common in EGFR-mutant non-small cell lung cancer, and the CNS represents a pharmacologic sanctuary for many drugs. Along with recent advances, development of novel drugs or combination strategies to address EGFR-TKI resistance without an identified resistance mechanism still represents an urgent clinical priority. So the implications for clinical practice are that given a substantial proportion of EGFR-TKI resistance is driven by unknown mechanisms, this creates a significant challenge in clinical practice and highlights the urgent need for research and tools to identify new therapeutic strategies. How do we address these resistance gaps? This requires an expanded testing and exploration of novel biomarkers to reduce the proportion of patients where we have an unexplained resistance mechanism. This would potentially enable more informed choices of second-line therapy and a broader uptake of targeted therapies instead of chemotherapy. On-treatment monitoring through liquid biopsy could enable earlier detection of resistance, allowing adjustment of treatment plans and potentially better outcomes. In the absence of novel biomarkers, we need strategies that have broader mechanisms of action for patients without actionable targets. These could include bispecific antibodies, antibody-drug conjugates, and novel combination treatment regimens. So to summarize addressing our EGFR-TKI resistance gaps, in the first module, we discussed biomarker-positive patients with actionable resistance mechanisms, such as those with MET amplification or HER2 amplification, where their treatments include potential addition of a MET TKI to an EGFR-TKI, or MET antibody-drug conjugate, or HER2-targeted therapy. In this module, we focus on patients without actionable resistance targets, where there's no clear available agent and no clear biomarker available, or the cancers do not exhibit any known biomarker. And here, potential treatment options beyond standard of care with broader mechanism of action may be necessary. And in our next video, we'll take a closer look at these approaches and how they may fit into non-small cell lung cancer treatment pathways.
Hello, everyone. My name is Dr. Helena Yu, and I am a thoracic medical oncologist based at the Memorial Sloan Kettering Cancer Center in New York City in the USA. In this section, we will discuss how to approach treatment when resistance mechanisms are unclear or biomarker-guided options are not available. I'm going to start by discussing what do the latest clinical trial data tell us about combination regimens in the post-EGFR-TKI setting in unselected patients. There are actually several novel drug combinations in this EGFR-TKI resistant setting. One such novel combination is the bispecific MET EGFR antibody, amivantamab, combined with platinum-based chemotherapy. In that same study, they looked at amivantamab with lazertinib as well as platinum-based chemotherapy, labeled the triplet and the quad regimen, respectively. The triplet regimen of amivantamab plus chemotherapy is currently approved for second-line treatment for patients with symptomatic systemic progression with multiple sites of progression. And this is all based on the MARIPOSA-2 study. This trial enrolled patients or allowed patients with stable asymptomatic brain metastases to be included. And in this patient population, this is a frequent event, and about 45% of patients on study had pre-existing brain metastases. The quad, the triplet, and chemotherapy were all assessed, with both the triplet and the quad having better benefit than chemotherapy alone. There was significant toxicity with the amivantamab, lazertinib, and chemotherapy regimen, leading that quad regimen to be put aside and the focus on the triplet regimen of amivantamab plus chemotherapy. The triplet of amivantamab and chemotherapy was superior to chemotherapy for all subgroups of osimertinib resistance, including those patients that had unknown mechanisms of resistance. The overall response rate was also higher with the triplet, 64% versus 36%, and we did also see improved intracranial progression-free survival with the triplet as well. Other novel drug combinations include assessing immunotherapies with platinum-based chemotherapy, similar to what is done in patients without EGFR mutations. And there have been several negative studies in this space, including chemotherapy with nivolumab, as well as chemotherapy with pembrolizumab. The few studies that have shown potential benefit of platinum-based chemotherapy and immunotherapy have also included anti-angiogenic agents. And one such regimen is the Empower 150 regimen, which tested a different quad regimen of atezolizumab, bevacizumab, carboplatin, and paclitaxel as a chemotherapy base. And on patients with EGFR-mutant lung cancer, there did appear to be a PFS benefit and an OS benefit with this regimen. Similarly, in Asia, the Orient 31 study looked at sintilimab, a different anti-PD-1 inhibitor with a bevacizumab biosimilar, along with cisplatin and pemetrexed. And early results from this study did show an improvement in PFS with this regimen compared to chemotherapy alone. We've seen data for ivonescimab, which is a bispecific PD-1 VEGF agent, along with platinum-based chemotherapy. And the study that assessed this regimen was the Harmony study. And something unique about ivonescimab is it is a bispecific antibody that integrates both PD-1 and VEGF blockade within a single agent, perhaps being more targeted to the cancer cell. And the Harmony study looked at ivonescimab with chemotherapy versus chemotherapy alone in patients with EGFR-mutant metastatic non-small cell lung cancer that had previously progressed on an EGFR-TKI. This study was conducted initially in China, but then later expanded to be a global study. About a quarter of patients had brain metastases upon study entry. Efficacy outcomes here, where the median progression-free survival with the combination was 6.8 compared to 4.4 with placebo and chemotherapy. The safety seemed actually quite similar between the two groups, with not significant additive adverse events with the use of ivonescimab over placebo, although there were some immune-related toxicities that were seen. But importantly, although there was a numerical benefit in overall survival with the combination, this was not statistically significant. And finally, in terms of additional combination regimens, one such regimen is continuing the third-generation EGFR-TKI with platinum-based chemotherapy. We already know that this regimen of chemotherapy plus osimertinib is approved in the first-line setting, but for patients that began with osimertinib monotherapy, there is new data from the COMPEL study that shows that continuing osimertinib while adding chemotherapy also seems to improve outcomes. This study focused on patients that had non-CNS progression and added in the chemotherapy to osimertinib. About a quarter of patients had CNS metastases at study, but again, that were non-progressing lesions. In terms of primary efficacy outcomes, the median progression-free survival was significantly better with continuation of osimertinib at 8.4 months compared to 4.4 months with the use of placebo and chemotherapy. There was some added toxicity with continuing osimertinib with chemotherapy, and most significantly, that was potentially some cytopenias, including neutropenia and anemia. The other efficacy outcomes were immature, but were trending in a positive direction for the combination, including median overall survival being 15.9 months versus 9.8 months, and the CNS median progression-free survival was 15.9 months with the combination versus 8.6 months. I'm now going to answer a second question. What trials are ongoing with antibody-drug conjugates in the post-EGFR-TKI setting? So Module 1 considered ADCs as a promising strategy to overcome both MET and HER2-driven resistance, but there are other antibody-drug conjugates that are under investigation in this post-EGFR-TKI setting that offer new options for patients with unknown resistance mechanisms. And two such targets for these ADCs include TROP2 as well as HER3. TROP2 is a cell surface protein that's overexpressed in many epithelial tumors, including non-small cell lung cancer. And there are multiple emerging TROP2 ADCs, including sacituzumab govitecan, sacituzumab tiromatocan, along with the approved datopotamab deruxtecan. HER3 is also a cell surface receptor that is frequently overexpressed in EGFR-mutant lung cancer, and such ADCs include patritumab deruxtecan, as well as isolantamab brengetican, shortened Izabren. As TROP2 and HER3 are frequently overexpressed in non-small cell lung cancer, a biomarker-guided approach to select patients is considered less necessary. The next question that I'm going to answer are, what are the latest clinical trial outcomes for TROP2-directed ADCs in EGFR-TKI-resistant non-small cell lung cancer? So first, we'll discuss datopotamab deruxtecan, which is the first approved ADC in EGFR-mutant lung cancer. It received accelerated FDA approval in June of 2025 for use after EGFR-TKI therapy as well as platinum-based chemotherapy. And this approval was based on a pooled analysis of two studies, TROPION-Lung01 that looked at Dato-DXd versus docetaxel, and TROPION-Lung05, which looked at Dato-DXd, and both studies included patients with EGFR-mutant lung cancer. Based on these studies, Dato-DXd did achieve approval and also demonstrated significant CNS benefit. Patients with asymptomatic brain metastases were allowed, and the intracranial overall response rate was quite significantly different in the two arms, with it being 38% in the Dato-DXd arm and 0 in the chemotherapy arm. And looking specifically at intracranial PFS, whether patients had treated or untreated brain metastases, datopotamab deruxtecan did appear better than chemotherapy. The TROPION-Lung15 study is currently ongoing, looking at datopotamab monotherapy, but also datopotamab with osimertinib compared to chemotherapy in the second-line setting. Another TROP2 agent is sacituzumab deruxtecan. This has FDA breakthrough designation. There was a previous phase 1/2 study that showed that this drug had enhanced efficacy in patients with EGFR-mutant lung cancer. And there is a currently ongoing study called OptiTROP-Lung03, which is a phase 2 study looking at sac-TMT versus docetaxel in previously treated patients with EGFR-mutant lung cancer. One thing to note is patients with active brain metastases were excluded, but the overall response rate was nearly triple with sac-TMT compared to chemotherapy. There were unique toxicities, including stomatitis as well as anemia, that we saw more with sac-TMT compared to chemotherapy. The final question I'll cover are, what are the emerging data on HER3-directed ADCs and EGFR-TKI-resistant non-small cell lung cancer, and how might these impact future treatment options? So the first drug in this class was patritumab deruxtecan, or HER3-DXd. It showed initial promise in a phase 2 study called HERTHENA-Lung01, which looked at this drug for patients who had received prior EGFR-TKI and platinum-based chemotherapy. And then there was a large randomized phase 3 study, HERTHENA-Lung02, that looked at HER3-DXd versus platinum-based chemotherapy after progression on a third-generation EGFR-TKI. This study demonstrated an improvement in median progression-free survival with HER3-DXd, 5.8 versus 5.4, but later results demonstrated a non-significant or no improvement in overall survival. And so with that data, the FDA BLA was withdrawn in May of 2025. Other such drugs in this space include Izabren, or BLB01D1. This is another bispecific monoclonal antibody that targets HER3 and EGFR. It also has breakthrough designation by the FDA. It was initially assessed in China. In several of the different studies that were looked at, there was a similar cohort of patients that had received targeted therapy but were chemotherapy naive, and you can see that the overall response rate in that earlier space was 58% with a median PFS of 12.5 months. There also was a really interesting phase 2 study looking at Izabren with osimertinib in the first-line setting, and we did see recent updated data at the World Conference for Lung Cancer that showed a confirmed overall response rate approaching 100%. And then there are other studies of Izabren looking at it in non-classical EGFR mutations as well as exon 20 insertions, but also in patients with EGFR wild-type disease. So some of the key takeaways, compared to chemotherapy alone, it does seem that these combination regimens clearly improve outcomes for patients with non-actionable EGFR-TKI resistance. And some such combinations, of course, based on the Mariposa-2 study, include chemotherapy with amivantamab, which clearly shows enhanced efficacy, but does have significant toxicity. There are also VEGF-containing immunotherapy options. Most recently, we've seen data for Harmony A. The Compel data highlights the value of continuing osimertinib if we're choosing to proceed with chemotherapy alone. And we really do need longer follow-up data to determine potential overall survival benefit with these different regimens. ADCs offer an alternative treatment for patients with unidentified EGFR-TKI resistance. ADCs, however, do have some unique toxicities that we will need to weigh against potential efficacy, and we'll consider this more in video 3.
In this next part, Dr. Yu and I will review some of the data presented in the previous 2 sections and explore the management strategies of EGFR-mutant non-small cell lung cancer after progression on osimertinib. Dr. Yu, when selecting a therapy in the second-line setting for EGFR-mutant non-small cell lung cancer with unexplained resistance, what key safety considerations should clinicians keep in mind?
Yeah, that's a great question, Pasi. I think that we have now actually, more and more options, but I think all of them have unique and different toxicity profiles. So some key safety considerations to think about: amivantamab has a unique kind of mechanism of action, being a MET EGFR bispecific antibody. So we see both MET and EGFR directed toxicities. So I think uniquely we'll see peripheral edema based on the MET inhibition, and we can see significant rash and paronychia with the EGFR wild type toxicities. When adding amivantamab to chemotherapy, you can also see increased hematologic toxicity, and that will be a trend with all of these combination partners with chemotherapy. Similarly, with osimertinib, you can see some added cytopenias, and I think clinically I've seen mostly added neutropenia and lymphopenia. And then with ivonescimab, the PD-1 VEGF bispecific antibody, you're going to see some novel immune-related toxicities, which can include rash as well as pneumonitis. And then, I think combinations always have slightly added toxicity. So, frequent kind of clinical monitoring and lab-based monitoring, I think, become important. Other unique toxicities, I guess, to mention is the infusion-related reaction that we do see with amivantamab. I do think that this will be mitigated with the sub-Q formulation that we will ultimately see. When amivantamab is in particular combined with lazertinib, we can see increased rates of venous thromboembolism. For second-line therapy, after patients have really just received osimertinib, most of them are able to tolerate the chemotherapy as well as some of these combination regimens.
And are there patients who you would not recommend one of those combination regimens?
Yeah, I think that there are. And I think that picking which one to use also really requires evaluation and a really kind of discussion with our patients about what their goals are and what toxicities are tolerable to them. I think for an older, more frail patient, chemotherapy in and of itself might be already something that, we're not sure about. But generally, I think for patients that are younger and motivated and fit, I do think that they can receive one of these regimens. And oftentimes I utilize the chemotherapy with the amivantamab if they haven't seen that before.
Dr. Yu, given the differences we're seeing in safety profiles with ADCs, how should that influence the way we're making treatment decisions and choose the right patients in the post-EGFR-TKI setting?
Yeah, ADCs, I think I would put them in the realm of chemotherapy, right? These are hybrid medications that certainly have chemotherapy-related toxicities. There are some unique toxicities with each of these ADCs as well. I'll start with Dato-DXd just because that's the currently only approved agent. I think some unique toxicities with Dato-DXd include significant mucositis or stomatitis. This often does require dose reduction and pretty aggressive prophylactic management, including kind of ice chips in the mouth during infusion and then prescribing dexamethasone rinses, both as prevention and treatment. We can also see pneumonitis with the ADCs, and that is, I think, a class effect that occurs across all ADCs, but certain ones do have higher incidences. It's somewhere between 5 to 10% with Dato-DXd. You can also see ocular surface events, sort of irritation of the eye surface, keratitis, that often require both prevention and treatment, but often starting with kind of saline drops to really make sure that the eyes stay lubricated. Just to highlight pneumonitis, it's something that if you're not looking for it, you won't see it. Patients have new shortness of breath despite stable scans. Re-imaging and really, pausing drug to assess for pneumonitis really becomes key.
I would agree. As we learn about and have more experience using ADCs, we learn also about the strategies to manage the toxicities. And I agree with Dr. Yu that ADCs, while a novel approach, the toxicities are still mainly from the payload, which is chemotherapy.
I agree, Dr. Jänne, and I think that as we now try to, with the different ADCs, continue the osimertinib or the third generation TKI, I suspect that we'll see both potentially enhanced hematologic toxicities, but we'll also have to look out for pneumonitis.
And one question I have for you is how does having prior pneumonitis of any grade on a patient treated with osimertinib, does that impact what you would choose in the subsequent line setting?
I think that is a great question. A lot of the clinical trials, or almost all of them, excluded patients with a prior history of pneumonitis. So we don't really have that data. We know patients that have had prior pneumonitis, whether it be from osimertinib or radiation, have higher risks of recurrent pneumonitis. So that would be a patient that, I would think about perhaps amivantamab and chemotherapy, because amivantamab doesn't seem to have a significant pneumonitis risk. And maybe, a person where if I had a PD-1 inhibitor, a VEGF combination available to me, I might, sort of avoid that or think a little bit more carefully before doing that.
Yeah, I would agree. I think these questions will need to be answered moving forward, since patients do get occasionally pneumonitis from osimertinib or radiation, and how that should be incorporated into the treatment decision is important. And as you point out, most trials will exclude those individuals, but I think what in real clinical practice, we may need better guidelines. Now let's talk about biomarkers for ADCs. This is obviously a field where we have very little in the form of that, except perhaps for Dato-DXd, where we know the approval is specific in patients with EGFR-mutant lung cancer, because that is the population where it was most effective. But do we have any understanding of why?
Yeah, I think biomarkers and ADCs is a important question that isn't just limited to EGFR-mutant lung cancer. By choosing to study these ADCs in EGFR-mutant lung cancer, there already is a selection or a biomarker there, right? It's EGFR-mutant lung cancer, where we know that HER3, TROP2, and even MET and HER2 expression are enhanced. So I think that's one way to select for a biomarker, are these driver mutations. But I think many of the things that we've discussed really are, right as of now, biomarker agnostic. I think because they included all patients with EGFR mutant lung cancer, there's no clinical evidence that looking for TROP2 expression or even, say, MET expression for amivantamab is beneficial. I think the one thing that we've seen as a potential biomarker for TROP2 has been recently presented, and that's using that kind of computational pathology, AI kind of supported approach called QCS-NMR, which is a normalized membrane ratio for datopotamab deruxtecan. I think it remains to be sort of seen how that biomarker, would be assessed prospectively, and it certainly requires further validation before routine clinical use. But I know as we have more of these ADCs potentially available to us, we need something to tell us, should we use a HER2-directed ADC versus a MET-directed ADC versus TROP2. So I hope that there's further work in this space.
I agree. And there are, fortunately, some trials that are trying to validate this QCS NMR ongoing. And we're hopeful that if, of course, validated, it is a biomarker that our own pathology laboratories can easily employ and use. I think one of the challenges is that at the moment it is requires an AI interpretation, which is not necessarily compatible with routine clinical flow, but hopefully things will continue to evolve. Let's now consider the challenges of choosing and sequencing therapies when no actionable resistance mechanism has been identified. And we're often faced with choosing between combination regimens, chemotherapy, immunotherapy, or ADCs. And Dr. Yu, in this setting, what are some of the consideration strategies you use to guide subsequent line therapy? And how do these other new emerging options like ADCs and other approaches like ivonescimab factor or even complicate these decisions?
Yeah, I think sequencing is something that, a lot of us are bringing up just now that we have some more options. I think in the second line setting and beyond is where it becomes really confusing. I think you've discussed this in module 1, but I think rebiopsying to, of course, look for histologic transformation and getting NGS to see if there is an acquired mechanism of resistance that's potentially targetable. But if we don't see an evident mechanism of resistance, that it really sort of depends on globally what you have access to. That, of course, affects, the therapies we can choose. But I also think adverse event profiles will come into play too, and discussion with our patients, right, Pasi, where I think, some patients, are okay with amivantamab-based toxicities. Some patients really don't want alopecia, and so then we avoid some of the ADCs. So I think we really have to weigh kind of patient priorities. And then similarly, though, in the second and third line setting, I think using the options that have the highest efficacy first and then kind of going on from there.
Yes, and I would agree that will continue to be a discussion with our patients about the potential options. I think we like to be most informed about choosing the second line option, and I agree with what you mentioned about rebiopsying patients' tumors, being able to look for histologic transformation, molecular alterations that may guide subsequent therapy. Thank you, Dr. Yu, for your perspectives and for sharing these with us. We have learned unexplained EGFR-TKI resistance in non-small cell lung cancer, which happens in up to 50% of patients treated with first-line, third-generation TKIs. We reviewed the standard of care after progression on EGFR-TKIs, including some of the recent advances, but chemotherapy remains a mainstay, and resistance gaps could be addressed with strategies that have a broader mechanism of action, expanded testing and exploration of novel biomarkers. We do have combination regimens that improve outcomes after EGFR-TKI therapy, such as the Mariposa-2 regimen, Harmony A regimen, and the Compel regimen. ADCs offer new avenues for patients with unexplained resistance, including TROP2, as well as HER3-directed ADCs. There's a lot of activity still ongoing in this space. We hope that the ongoing trials will give some clarity to the use of these agents. All of this requires careful patient selection, monitoring, and management. Make sure that our patients not only have the best possible outcome, but that they're able to tolerate them, and where we can help potentially manage some of those side effects or potentially prevent them from happening. In the next module, we will discuss the role of biomarkers in EGFR-TKI resistant non-small cell lung cancer and how we can advance biomarker strategies.